Good afternoon, everybody. Welcome to today's Improvement Showcase from the CEIH in Series 1, Improving Flow. This is our third session, and we're really glad to see that you've been able to join us live. And for those of you who haven't been able to join us live, thanks for clicking on and having a look at our video. So our CEIH Improvement Showcase has been established to give South Australians working in providing healthcare the opportunity to share their stories of improving systems. And we're really excited to provide, I guess, an initial forum, and looking forward to iterating and developing this forum so that it meets the needs of the system. And so we look forward to hearing your feedback and hearing ideas about how we can do this differently and how we can evolve. Before we get started today, we'd like to acknowledge that this land we meet on is the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the traditional custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. In addition, I'd like to acknowledge other lands that some of you may be sitting on today, certainly where I am up here in the hills working from home today on the land of the Pemberton people. So what if the big idea was connecting all of the small ideas? And this is really what we're trying to do by bringing you together and giving a platform that's quick and simple and gives you the opportunity to talk to other people who are also trying to solve many of the problems across our health system. In Series 1, Improving Flow, we've heard so far from Angie and Jane down at Flinders around the integrated management system. Last week, we heard from Martin at the ambulatory gynecology unit at Modbury. And this week, we welcome Peter and Jaff from Flinders Medical Centre, who'll be talking about supporting quality assertive discharge. Next week, we're looking forward to welcoming the team from the Carlin Day Rehab Service, who'll be talking to us about their amputee prehabilitation program. So the CEIH Improvement Showcase, Thursdays at 1 o'clock, and then online whenever. But certainly for those of you who've joined us in the flesh today, or on the screen live today, I should say, we will be stopping our recording at the end of the presentation from Peter and Jaff to give you the opportunity to turn your cameras on and open up the conversation and provide a platform for discussion straight after the presentation. So the video goes off at the end of the presentation, and you can turn your cameras on and feel free to have a chat about whatever it is that comes to mind after you've heard from Peter and Jaff. We really want to provide that space to explore what others have learned and keep it simple. So at the end of the presentation, if you think, gee, I've got a story to tell, and I think that this is a platform where I'd feel comfortable telling it, you succeeded in solving a problem, or you've learned something whilst trying, or if there's other themes you'd like us to explore in these sessions as we go on throughout the year, please don't hesitate to get in touch with us at the CEIH, and you can find a contact us form on our website, or if you know one of us, just give us a ring. So without further ado, I'm going to hope for no technical difficulties and hand over to our colleagues Peter and Jaff, who can give their full introductions when I hand over to them down at Flinders Medical Centre. Thanks, guys.
Thanks, Katie. We'll just attempt to share our screen.
Okay, hi everyone. My name is Peter Woodcock, and I am currently one of the case managers within the squad project. And we have Jaffa Liensavan, who's one of our project managers that's been with us for quite a while now. So SQUAD stands for Supporting Quality Assertive Discharge. As I mentioned, Jaffa is one of our project managers, and also there's another lady called Lisa Gilbert. They job share that role. We currently have 2 case managers, myself, and my background is nursing, and we have Brooke Greenshields, who's joined our team recently, and she's a senior physiotherapist. Within our squad team, we also have a therapy or restorative team, and that currently consists of Alex Stewart, who's a physiotherapist, and Ria Hipper, who's our allied health assistant. So SQUAD initially was developed late 2019, and we found that within the long-stay patients at Flinders Medical Centre were taking up an overall proportion of our beds within the acute care system. And as you can see, within the 2019-2020 financial year, the Health Roundtable report indicated that it occupied 15.5% of our overall bed days here within SALHN, and that placed us at 11th amongst 20 other hospitals within the country. Noting that there's 2 other SA hospitals there, one above us at the time and one below us. So, prolonged stay of patients. We find that unnecessarily prolonged stay of the long stay patients, which we were looking at greater than 14 days, we consider a long stay patient, are harmful for them. They can lead to an increase or decline in their overall physical function. While they're waiting here within our system, they often have periods of inactivity. So they could be waiting for ongoing tests or becoming medically stable. Their inactivity can result in sleep deprivation. As a result of all of these factors, they can have episodes of confusion or delirium. This again can result in a falls risk or in some ongoing hospital-acquired infections. So the Supporting Quality Assertive Discharge team was formed to trial a range of assertive complex case management and supported discharge strategies to transition the long stay and maintenance care patients out of hospital. We based the project on successful initiatives trialled in other healthcare organisations. The objective of Squad was to simply support the patients to return to their usual place of residence. So we split our presentation into 2 phases of Squad. The first phase commenced in December 2019 and went for 7 months to the end of June 20. At the time, we had some case managers who identified long stay patients. So again, that's anybody over 14 days. And we looked at discharging patients through proactive discharge management facilitation. Our restorative team commenced in March, and the idea of this team was to increase therapy from not only their single session they received from the acute teams on the ward, but we wanted to increase it to twice a day. So phase 1 consisted of 3.5 case managers, so social work, occupational therapy and nursing, and we had 2.5 full-time equivalent in the restorative team, physiotherapy, occupational therapy and the AHA. So in many cases, there was a range of complex factors that were present that posed barriers to the usual discharge pathways, and this required intensive clinical input, excuse Jeff, negotiation with a range of its internal and external stakeholders, and we just looked at devising novel and innovative solutions to transition patients out of hospital. So a lot of things just was along ongoing discussions and communication with outside sources. I'm going to hand over to Jeff here.
All right, thanks, Peter. I'm going to talk about some of the data stuff that was happening, I guess, in parallel with the different phases of Squad. So at the end of phase 1 of the Squad pilot, we did notice a reduction in that proportion of bed days that complex patients were taking up. So we saw a reduction from 14.51 in December to about 11% at the end of June. Now, those with a keen eye to the first slide would have noticed that the Health Roundtable slide had Flinders at 15.5. And the difference in their percentage and our percentage is because Health Roundtable measured long stay as over 21 days, and we were counting long stays over 14 days. So that's the discrepancy that you'll see. In that phase 1 period, we were involved in a number of patients. 120 of those patients had a hospital stay of more than 14 days. 30 of those had a length of stay of over 30 days. And when we plotted that quarterly, it looked like it was 14.5, 15-ish, 13, and then sort of at the 11.5 mark. So I guess a few caveats on this slide. You know, whilst it looks like we were heading in the right direction, I think we can't discount, I guess, the weird period that we were in with COVID, and also acknowledging that squad was just one initiative amongst others that may have been happening at the local level and at the ward level.
So then moving on to phase 2, so July to October, so a period of 4 months, we took some learnings and outcomes that we learned from phase 1. And through these learnings, we improved engagement within the SALHN divisional leadership. We then co-designed a model that we wanted to trial on a general medicine unit. We defined the patient cohort, and then we agreed to trial interventions, which I'll talk about, on 2 of the general medicine units. We have 5 here at Flinders, so we chose just to focus on 2. The squad team, you can see, then consisted of 2 case managers, 1 therapist and 1 HA. So we looked at 5 key interventions. We designed, using some other resources, a screening tool that was looking at patients at risk of increased stay. We assigned a case manager to these patients. We set a criteria for their discharge. We also provided increased therapy to these patients which were identified at having or being at risk of clinical decline. And we also provided a discharge to assess visit. The idea, unfortunately, our link to a very quick video isn't available to share with you, but we will post it afterwards if anybody wants to have a look at. It's a really good tool that explains assessing the patient in their home, in their own environment, instead of using what is very different here within the clinical setting, whether it be a kitchen or a bathroom setup or just them being in their familiar environments. And we had really great success with these discharge to assess visits. After developing the screening tool and implementing it, we looked at the patients that were at risk of long stay. There was 480 patients we screened, and 225 of these patients were deemed at risk. Basically, we found that the tool was not sensitive enough to differentiate between patients with a usual care, even though they may be complex, they still had a usual care and had a pathway, to those that were extremely complex, requiring additional management to try and get them facilitated out of hospital. We also acknowledged that 47% had a combination of not only complex chronic health, but also psychosocial factors, and this increased their risk of long stay. Phase 2, I think, basically showed that there was a reduction in the proportion of bed days. We went from about 14.51 to 10.7%. The bed day impact reflected a reduction of around 17 beds. We proactively case managed 225 patients. Of those 225, 54 of them were provided additional therapy, and as a result, 52 returned to their usual place of residence, acknowledging that it wasn't just squad, it was also all the acute teams and disciplines working. And during the 4-month period, we did 26 discharge to assess visits. Of those 26, 21 remained at home. The 5 that did return to hospital, we had good plans of where they needed to be to either get home or whether we need to look at a different pathway for discharge. We thought we'd just quickly give you a couple of case examples over the learnings of the first 2 phases. So the first one is Mrs. M, who's a 52-year-old female, usually lives in Minder supported housing. She has a known intellectual impairment. Previously normally mobilising independently unaided, did receive some support from her carers, but primarily independent. She had a fall at home, sustained a fractured pelvis. Treatment was going to be conservative and weight bearers tolerated. Within her first initial period in hospital, there was multiple bed moves, a lot of them due to her behaviours, being in an unfamiliar environment, quite scared, no carers that she knew around her and trusted. Participation as a result with physiotherapy and intervention was very limited. At the time, we decided to take her back to her home. So we did a discharge to assess visit. Unfortunately, there was some improvement, but she did require to come back into hospital. That basically allowed us to determine where we were going to go with her care and how we could improve her function for her to be able to return home. We supported some Minda carers coming in over the next days to try and engage during our physiotherapy sessions. We then, again, participation improved, but it still wasn't at the level that she could go home. As a result, we accessed some funding. We increased her carer support within her home and discharged her back home. As a result of that, after 3 weeks, we again went out to her home, assessed her, and she was back at her functional baseline. I guess the risk of this lady not being able to have these discharge to assess visits and setting some goals was that she would have never have returned home and had to go to high level care. Very quickly, another one is Mr. S, 68-year-old gentleman, usually lives home alone, admitted with delirium and a respiratory tract infection. Due to his confusion, he was detained under the Mental Health Act. Previously at home, minimal formal supports, very good family, mobilising independently. Again, within the hospital setting, he was very delirious, not participating, becoming quite aggressive. We decided to work with the family, take him home. The medical team agreed to lift his detention for the day. We took him home, assessed him in his own environment, and he was back to his functional baseline. So then we brought him back, had the detention lifted, and he was discharged home. It just again goes to show that once we can medically treat their acute stage of their illness, the best place for them is home.
All right, so I guess some of the collective outcomes from both stages 1 and 2 of squad, I guess we had to appreciate that we weren't the first or the only project that was looking at long stay patients, and tried to understand why other initiatives sort of came and went and didn't really have that sustainability. Peter talked about a lot of the clinical outcomes that we were able to achieve, but we also wanted to measure how we'd be able to sustain this financially, keep it effective, and have a model that we were able to, I guess, quantify our goals and any other really, I guess, future initiatives against. So we were lucky enough to partner with the Flinders and the National Medical Research Councils to help us build, I guess, a health model. And I'll go to the next slide. And it's a real health model based on a myriad of data sources, which in short captured every single patient that came through the doors at Flinders over 2019. It goes on to track the obvious, like your length of stays, the costs associated with each of those patient journeys, I guess the clinical effort in terms of internal referrals within different specialties, allied health and nursing specialties and medical specialties. And I can talk more about this maybe after the presentation if you're interested, but long story short, we were able to map for Flinders every patient that came through the door. And I guess what I'm showing on screen, just highlighting in orange, 2 real pathways. So one of them is patient comes through the door through ED, goes to the ward, and from the ward, they go somewhere else that's not home. If you sort of track along that line, the average length of stay for that patient journey is about 16 days. The other real journey that we find at Flinders is the bottom line that I've highlighted, and that's someone coming through the door, going to the ward, getting referred to a GEM or a rehab pathway, and even from that pathway, going straight home. On average, that that's equivalent to about 17 days, average length of stay. The green pathway I've highlighted is a pathway where a patient, again, comes through ED, goes to the ward, and from the ward, they can go straight home. So if we can adjust anything that we're doing to get the patients on that trajectory, that gives us an average length of stay of, it's a bit small, I think it's 6.4 days. So I guess all of our initiatives were focused on trying to get patients back to their usual place of residence and trying to continue their care in their own setting. The model goes a lot more complex than that, with all of these different, I guess, probabilities of readmission, probabilities of mortality, but I won't go into those today.
All right, very quickly, just looking at both phase 1 and phase 2, 963-day long stay patients were looked at. 383 of them were not medically stable for discharge. However, of the ones remaining, 5 key barriers were identified. A lot of them waiting for further assessments, ACAT, SACAT, neuropsych, NDIS supporting, or even applications. Next was mobility and ADL function. Then there was the patients or their families deciding where they wanted to go for many different reasons. Some just generally awaiting other supports and then awaiting internal hospital beds. For the project, there was a customised web-based portal that was developed. It was real-time information that we as a team were able to access for any patients that were highlighted across SALHN for long stay patients. So again, 14 days or over. It also, for those patients that we saw under 14 days, we could manually enter it. So very quickly, this is a quick snapshot of what one of the pages looks like. You can see it's broken down. We can go into any hospital within SALHN. Flinders no longer a repat, and we can then break down again how many days we want them to be looked at, whether they're monitored, whether we need to add them to our system, whether we need to look at them. So a very quick snapshot of that's where we sourced our data from, both manual and automatic entry. And we can share that further afterwards if anybody wants to look at it more live time, hopefully. And again, very quickly just outlining case management. Case management definitely altered depending on staff availability, staff changes, inconsistency, absences. There were some days lost as a result of that. Proactive identification of alternate pathways and consultation. Reduced number of referrals if there was less case management for our therapy team. And then at times the communication from outside sources could often be less. The restorative team on average saw patients for an extra 5.3 hours of therapy per month as a result of us increasing their therapy session. They engaged in a holistic therapy program, not only just acute care on the ward, but also taking them outside for duct pond therapy or outside of that four-wall acute ward. We looked at progressing them to return home at times without the inpatient rehab or GEM admissions. Or at times we just sped up that pathway and got them to those areas quicker. We also prioritised our patients based on whether they were able to go home that day or not.
All right, I talk about this slide with a level of caution because it does have some dollar figures involved with it. But nonetheless, if we went back to our original metric of looking at the proportion of bed days that the complex long stays were taking up in our system, that was 14.51 days back in December 2019. At the end of phase 2, October 2020, at that point in time when we had a look, we got it down to 10.77. And again, I don't want to say we as in squad did that alone. Other initiatives were happening, other things were happening in the system. COVID was still ticking along. So there were other things happening. But if we measure that reduction of 3.74%, that's the equivalent to about 6,000 OBDs. And if you do the division over 365, it's the equivalent of sort of 16, 17 beds. We did set an optimistic target to try to get to 9.5, like the percentage 9.5, because that would have yielded us a saving of 24 beds, and we could, you know, say we saved a ward. We didn't quite get there at the time of evaluation. And again, I still want to emphasize the caveat that we're not wholly and solely responsible for that. And I guess just to loop back, because we started with it, Health Roundtable proportion of long stay beds for Flinders, we, again, different metric because Health Roundtable was using 21 days, but we did see an improvement on the Health Roundtable metric of 21 days. We improved 1.5% and sort of put us sort of just over the middle of our peer hospitals. But I guess putting all of these learnings together, you saw the preview of the portal that Peter had, our work with the health economists, and you would have seen our colleagues present the tiered system, like the integrated management system. I guess it gave us the tools to be able to predictively intervene with patients that were at risk of becoming long stay, rather than reactively going, oh no, we have this many patients that are over X amount of days in our system, what do we do? So that's our last slide. We will thank you for listening to us. Hand back to Katie to, I guess, stop the recording and open up to questions about anything you want to talk to us or ask us about.
Thank you, Jaffa, and thank you, Peter. That's